again. Good morning, everyone. I'd like to make this talk interactive, so you can always stop me if you have any questions to ask. I'm supposed to do it in half an hour. I don't know how I can do it in half an hour. Get these slides. As you all know, bladder exstrophy can be a spectrum of conditions. The most severe one is the bottom on the right-hand side, which is called collateral exstrophy, which is a little bit different than bladder exstrophy in that you also have the bowel, which is right in the middle here that is in between the two bladder halves. It's not as common. The most common is bladder exstrophy. And I'll pretty much concentrate my talk on bladder exstrophy rather than collateral exstrophy. I'll talk a little bit about collateral exstrophy and the other end of the spectrum, exstatus. It can be either exstatus with testicular incontinent or exstatus with testicular continent because of safety muscles. And the earliest reports of bladder exstrophy were in tablets in the 2000 BC. There were descriptions back in 1595. It's more common in boys than girls, 2 times more common in boys. So you all know what the defect is. The umbilicus is right on top of the bladder plate. We call this a bladder plate, which is basically the exstrophy bladder. The belly button is lower than normal. And in the male, I'm going to talk about male exstrophy. In the male exstrophy, you also have the urethra, and the bladder makes the urethra not formed. This is a description in a boy where you have the umbilicus being lower, the bladder plate itself, the penis is usually angled upwards. That's called dorsal B. The pubic bone is separated. There's also a distance between the penis and the scrotum. Usually the scrotum is normal, the testicles are normal. Next slide, please. In bladder exstrophy, and those are from studies from the mentioned Dr. Swanseller, Benedict contributor in the pelvic anatomy in bladder exstrophy. The pelvis itself is abnormal in bladder exstrophy. It's usually tilted backwards. Ones that you all know is the diastasis of the symphysis pubis. The pubic bones are close together. In exstrophy, they're separated. The iliac wings, which are those 2 wings here, are flatter than normal, are more vertical than round, and there's also anterior displacement of the pelvic floor. Next slide, please. And then the musculature is also abnormal or different in bladder exstrophy. Next, can I get the next slide? Because I can't advance it here. This is a schematic of the normal anatomy. So you actually have this is a cross-section view. You have the perineal body, the urethra is right in the middle here, the symphysis pubis is right together. Next slide, please. And in bladder exstrophy, what you have is the urethra is flat. It's not circular. It's not within the perineal body. So it's on top of the penis, and the symphysis is displaced, sometimes quite significantly. Next slide. There's also abnormalities of the pelvic floor, basically meaning the muscles that support the pelvis, and in bladder exstrophy, the sphincteric mechanism is more backwards than forwards than it should be. And a lot of patients with bladder exstrophy are born with the anus being a little bit higher than normal. Next slide, please. So the goal of reconstructing bladder exstrophy is initially to close the bladder, repair the bladder neck for continence. One of the issues that we face with bladder exstrophy is that there are two types of sphincters in the normal individual. There's what's called the internal sphincter, which is basically the bladder neck mechanism, and there's also the external sphincter, the sphincter that we basically use to control um, our bladders, and that external sphincter is not present in, or is not functional in patients with bladder exstrophy. So we really have to rely on the bladder neck for continence and thing bladder neck for continence. The second goal is reconstructing genitalia and making it anatomically functional. There's quite a few talks there. Female reconstruction also. The most important thing with bladder exstrophy is preserving kidney function. Because of the fact that the bladder is open to the outside, once you close that, it's a small bladder, there's a lot of pressure on the kidneys at the initial closure that cause problems or issues with kidney function. So it's really important to monitor that closely after repairing the bladder. And the importance of reducing morbidity and improving the quality of life. Next slide, please. The first attempt, there were several attempts in repairing bladder exstrophy. The first attempts were not successful. They were just basically trying to close the defect skin flaps on top. And then in the early 1950s, 60s, what they ended up with all patients with bladder exstrophy ended up having is their bladder taken out and creating what is called the division chief, basically taking a piece of intestine, hooking the ureters to the piece of intestine, that stoma to the skin. And that's how patients with bladder exstrophy used to live until probably the 1970s. A person was involved in reconstructing these types of patients, giving it a quantum version of Dr. Hedger at Boston Children's. And so that was probably up until the 1970s, late 70s, the patients with bladder exstrophy treated that way. Still, next slide, please. People don't know about Dr. Julian Ansel. I suspect that Dr. Mitchell got his inspiration to close bladder exstrophy by Dr. Ansel. Dr. Ansel was a urologist at the University of Washington, and he was one of the first individuals who did a complete primary repair of exstrophy as well as his exstrophy and published that in the 1960s, but never gone into the problem with the initial closure is that there was a high likelihood of damage to the kidneys from that initial closure. And that's when Dr. Bob Jeffs was at the University of Toronto and sick kids in Toronto and then moved to Hopkins, described a multi-stage repair. The idea behind the multi-stage repair is to stage repair so that you don't cause that increased pressure in the bladder and cause damage to the kidneys. So the initial closure, we're just closing the bladder without doing anything to the bladder, so they're continuing to be incontinent, doing the repair of the epistatus, basically the urethra itself, and then later on reconstructing the bladder neck for possible continence. You've heard about Dr. Mitchell. Dr. Mitchell was an innovator, or is an innovator, a master surgeon, and he's the one who described the complete primary repair of exstrophy. You've heard a lot of people here talk about there having multiple operations. So the name is kind of a misnomer because it's really not a complete primary repair, because a lot of these kids that have PREs do get multiple surgeries. But the idea behind Dr. Mitchell's repair is to repair everything in one step. Pretty much closing the bladder, doing the bladder neck reconstruction, repairing the urethra, all in one step. And the idea behind that was, if you can go back a little bit, the idea behind that was that hopefully by doing that and doing the operation correctly, maybe we can get away with just doing one operation, only having one operation to gain the important part of this if there's gain confidence later on in life. Next slide, please. So today there are pretty much three approaches to the repair of bladder exstrophy. The modern stage repair of exstrophy, that's the one that's advocated by Hopkins. They pretty much do it as a stage repair, their initial stage, and that's why it's called the modern stage repair. They do the bladder exposure and the bladder reconstruction once as the first stage, and the second stage is the phase repair. The complete primary repair of exstrophy is the one that we perform here. It's the one that we perform with a collaborative in India. And it's more popular in Europe than in the United States. It's the third operation called the Kelly procedure. It's a procedure that has more mobilization of the penis from the pelvic bone to create a better appearing penis, but then in males, but then those kids do not require osteotomies. But again, this is a procedure that's mostly done in, and I'll talk about that. The results are pretty good overall, but my concern is that for the complete primary repair of exstrophy, when we reported our first result, because when you look at the long-term results, they're not as they were initially publicized. Next, and again, initial start procedure, Dr. Beatty was one who advocated it at Seattle Children's around the world. So the goals of management, I think the major goal, the initial goal is to protect the kidneys, make sure the kidneys are protected. The second goal is to gain continence of urine and finally have functional genitalia and have a satisfactory cosmetic outcome. The problem with bladder exstrophy and the published data with bladder exstrophy is that the series are small, because even in big centers they only see 6 to 8 patients a year, and so you don't have long-term results and large results. I think now with the collaborations, we hopefully be able to do that and then come to a consensus. What is the definition of continence? My definition of continence is different than yours. What is the definition of normal erectile function? And really, there's a limited long-term follow-up right there. I think with the collaborators right now, looking at long-term follow-up, looking at quality of life issues, and really comparing different techniques to try and provide the best possible outcome for patients with bladder exstrophy. Next slide, please. So the natural history. So the first thing I think we need to figure out is that, well, what if we don't operate on these patients? Is that an option? And so next, the problem with that is that there's significant morbidity associated with that. Kids that have and we've seen people in India have not been corrected for years. There's a kid that we're trying to operate who's 28 years old from Mauritania, never been killed before. They have incontinence, they've got chronic urinary tract infections, bladder pain is an issue. Next slide, please. And then those patients go on to have limited to actually no sexual function. There's issues with the kidneys, and there's the issue of cancer developing those bladders that are exposed to the inside. Before osteotomies became common in repair of bladder exstrophy, osteotomies, as Anna mentioned, it is breaking the pelvic bone. Sounds awful, but that's pretty much what it is. It's breaking the pelvic bone. Before the osteotomies, there was a high incidence of bladder dehiscence, just because, in fact, there was a lot of tension on the bladder, not a lot of the bladder to heal well. The conscience of defect and continence rate was lower. I think that the osteotomies that were initially they were done from a posterior approach, not from an anterior or front line approach. We've been able to, most of these repairs are really successful without dehiscence. Next slide, please. There are different types of osteotomies. As I said initially, we started with the red lines that are posterior osteotomies. What we currently do is iliac osteotomies, but done from the front, because we don't have to make two incisions. One of that comes from the initial osteotomies that were basically authorized at CKs in Toronto, were done not at the same time. So they would do the osteotomies first, and then the kids would recover, and then they would do, the week later, they would do the bladder exstrophy. So they would do the osteotomies and closure at the same time. Next slide, please. And when you look at predictors of outcomes, if you look at what is the most important predictor of continence, so look at patients that are continent, and the most important predictor is in the success of closure. So this is from the Hopkins group. They described with successful primary closure, there's usually an 80% chance of continence, but then when they have failures, the continence rate decreases. And it's intuitive, because one close the bladder next to the bladder initially and it's successful, you have adequate bladder volume, because bladder volume is actually one of the other predictors of continence. And if you have a bladder capacity of 400 mLs, which are around 3.5 ounces, at the time of bladder neck reconstruction, you have a better chance of successful closure or successful reconstruction of the bladder neck than if you have smaller. Next slide, please. And this is several articles that just look at on the right side. So you notice that with the osteotomies, the rate of successful closure is close to 100%. The last two are the Kelly procedures, and again with them, over time they reach a pretty high success rate with the Kelly procedure in having successful initial. Next slide, please. So the current recommendations for osteotomy is, if, and we don't do those, the repairs are not done in the past, they were done in the newborn period. Especially that was after going to India, starting the India initiative, that even if you close them later on in life, you can actually have a successful closure. So right now we allow patients to grow, we allow them to go home, and we usually operate on them between around 3 to 4 months of age. What that allows, it allows for the males, especially, there's usually in the newborn period, there's a surge in testosterone, the hormone that allows the kids to grow. So that hopefully makes the operation of fixing things easier. We operate on them after 3 months of age. Secondly, there's bonding with the family, rather than snatching them away from the family, from the parents of the first day of life. And so the repairs are done delayed, so we don't do them in the newborn period, but if they were to be done in the newborn period, we do them in the first week of life. The pelvis itself is quite lax, if you're able to close it, unless the diastasis is greater than 4 centimeters. If the diastasis is greater than 4 centimeters, we recommend osteotomies. But osteotomies are recommended for all of the pediatric closures. Next slide, please. From the type of bladder operations, the osteotomies are probably the most painful for those infants, and have to make sure that we actually provide adequate pain control after surgery to allow them to heal. Next slide. Kidney function, there are different reports regarding kidney function long term. This is on the left side, there's an article from the Hopkins group where they basically had no issues with kidney function. But overall, when you look at the other series, there's anywhere between 15 to 25 incidents of upper tract or upper tract basically meaning kidney changes. Next slide, please. In our series in Seattle, 70% of the patients had some form of hydronephrosis, which is basically fluid in the kidney, but that wasn't persistent fluid. And so as you close the bladder, there's pressure on the kidney, so there's hydronephrosis and damage. And and it gets better over time. But still, around 2% of kids have chronic issues that we have to deal with. And other serious report 10 to 30%. So it's really important for us to watch the kidneys as we're operating and making sure that kidneys are protected. Next slide, please. Because the issue of vascular-uritic reflux, you probably know that every closure, because of the high pressure, there's backup feeding to the kidneys. And when we looked at our series in India, we saw that around 70% of kids that had their initial closure eventually needed some form of repair of the reflux. So now the reflux repair, if the bladder plate is adequate, is part of the initial closure. And it's only been in the last 5-6 years that we started doing the urinary implants at the time of closure, fixing the urinary time to prevent reflux, and especially in females, to prevent kidney infections. Next slide. So kidney function is normal in newborn periods. Long term, most kids have normal function. Some have slightly decreased function. Most don't need a transplant. And hopefully today, no one should have a transplant after bladder exstrophy. So it's totally different than follicular exstrophy. And I'll talk about follicular exstrophy as multiple other kidney anomalies within cause kidney damage. But again, there is a subset of patients that do have acanthosis and do have kidney issues. And so it's important for us to watch those. For example, with our India initiative, we have a nephrologist that comes with us on a daily basis, and she evaluates the kidney function of all kids that come to that workshop. Next slide, please. So from kidney recommendations, really following those kids very closely, making sure that their kidneys are protected. It's our main goal as an initial closure. Next slide. Next, as we get through kindergarten, first grade, we need to talk about continence, making them try, at least getting kids to be socially continent. The results are extremely variable from the report that we have, anywhere between continence rates of 7 to 85%. Most kids have abnormal boiling patterns, but there's a large percentage that require some form of reconstruction, mainly closing the bladder, adding intestine to the bladder, creating a catheterizable channel. There's issues with the muscle of the bladder thinning long term, can cause issues. Most kids that have been there without reconstruction. Next slide, please. There are different types of, I'm not going to into the details of it, but there are different types of bladder neck reconstruction. So what we do with the bladder neck, the opening between the bladder and the outside is wide. So that's what causes the incontinence. The idea with the bladder neck reconstruction is to tighten that opening so that the bladder can hold more urine. But again, as I said, kids with bladder exstrophy don't have that external sphincter, don't have that control of being able to control their urine, so they have to be on a time schedule. So the only way they will be continent is if they go to the bathroom on a regular basis, because if they don't, as the bladder expands, the pressure in the bladder gets high enough that they can leak out, because they don't have that external sphincter control. There are different types of operations. The second type of operation, the idea behind the bladder neck repairs is really tightening the outlet, the opening between the bladder and the outside. Next slide, please. Next slide. I think the issues that we've had in defining what is continence, I mean, is it dry by day, dry by night, both? Is it dry for 3 hours, 1 hour, 2 hours? Is it dry on thin and catheterization? And I think when I talk to families and we talk to families, I think parents' definition of continence is probably the more important one. What we talk to families, we ask yourselves, what is continence? It's being on your own and being dry both day, at least for 3 hours, and preferably dry at night also. As I said, the initial reports on continence were very low. And the reports initially said that it came 60% patients with bladder exstrophy continence outside of operations. This is a more recent report from the Hopkins group. And when you look at their long-term perspective, there are over 400 patients with bladder exstrophy. Only 25% of the patients are able to avoid positioning urinary tract without aid. So 75% are not people. Another 64% of those that have reconstruction, so even the bladder neck reconstruction is not 100%. So 64% continence after bladder neck reconstruction. When you close the bladder neck, you augment and you do the trophonol, then the continence goes up to around 93%. Again, it's a big operation to get to there. There's several other reports. There's a report from Indiana that looked at their continence rate is 8% before the bladder neck reconstruction, 15% after bladder neck reconstruction, and close to 7% after bladder augmentation. The next one is from France, where they had a 9% continence when they did a bladder augmentation with trophonol. They use sphincters. There are artificial sphincters that we used to use in the past to repair bladder exstrophy, tighten the neck of the bladder exstrophy, which don't use today just because the complication rate of these sphincters is much higher in the exstrophy group than in others. When you look at our studies in Seattle, the initial report, and Dr. Schnell-Warren is here, she's the senior author on that report, talked about 74% continence with volitional avoiding. 20% of the boys and 43% of the girls were continent after their alone. And then another 18% was using blocking agents of the bladder neck. And when we further went on and looked at the long-term outcomes, they're not as good. Only 16% of our patients after CPRE alone are continent. And the increases around 34% after bladder neck reconstruction. And those results are pretty much the same, also show the same type of group. And Dr. Krieger will talk about the MIDEC group, and I think that the results are pretty much the same. But the category pair, similar results. The Great Ormond Street is presenting results that are higher than what we're expecting, and it's an operation. It's in its infancy right now. I think the long-term results will tell that the operation is a better operation so far. Next slide, please. So when you look at the approach, I would like to divide it into two: the John Hopkins approach and the Doug Canning approach. So the John Hopkins approach with the multi-stage repair, they follow patients on a yearly basis, they do cystoscopies, they assess their bladder capacities on a yearly basis. And you usually around first grade, second grade, they divide patients into two groups: those with a capacity of greater than 100 ml. Those patients will then go on to have bladder reconstruction. Those bladder capacities that are less than 100 ml, because the continence rate with just the bladder neck reconstruction is not as successful, they will then go on to do either bladder neck reconstruction closure, bladder augmentation with trophonol. There's the Doug Canning hypothesis, and that came out from the Indian Collaborative. And his hypothesis was that those bladders are normal to start with. You close them, they should be normal. And so if you do the operation correctly, you construct the bladder neck correctly, you close the bladder correctly, those bladders should grow over time. And his thoughts were at patients. Wait for these bladders to grow. They will not, maybe not grow to adequate size by the time they're 7, 8 years of age. Maybe you need longer time to get them to be continent. We've seen teenagers who go through puberty and become continent after they reach puberty. So it's something to think about. In our Western society, we like to be out of diapers when they're in first grade, because they can't go to school sometimes if they're in diapers. So something to think about long term, that those bladders bladders will grow, and his concept was that if they are allowed to grow, then maybe that will allow them not to have the major reconstruction, which have morbidity. People with bladder confusion, it has its own limitations. Next slide, please. As far as the genital are concerned, it's providing adequate genital for males. In the male exstrophy patients, they do have a functional penis, but they're short. There is a 20-30% revision rate in reconstruction of the penis. With a complete primary repair of exstrophy, and it's something we watch for very closely. There has been damage to the penis. That's something that we look for during your repair, because bringing the pubic bone together sometimes can cause tension on the penis and cause issues with blood supply. So we watch that very carefully in the initial repair to prevent that type of damage. We know that from psychosocial aspects, Dr. Reiner is here as big advocate for the bladder exstrophy community. We know that the quality of life is decreased versus normal control, and the recent study from Indiana has shown that if they are continent, the quality of life is much better. That makes sense. Next slide, please. There are concerns in the males with bladder exstrophy, in the way the penises appear, their functionality and fertility. Next slide. This is an average penile length in a normal person. It's around 10 to 15 centimeters in length. The circumference around 12.1 centimeters. And then in exstrophy, the penile size is smaller. The girth is larger during erections. And next slide, please. And that's what you see with bladder exstrophy. Bladder exstrophy, mainly because of the separation of the symphysis. The penis itself is shorter. We try to make the penis longer by bringing the symphysis with the pubis together, but still, the penis is shorter by around 40% in the male exstrophies. Next slide. And when you look at studies over time, erectile function is thought to be around 90% in most of the patients with bladder exstrophy. There haven't been a lot of studies that are looking at cosmetic outcomes that have been documented. Next slide, please. From reports, 40-60% of MH patients are sexually active. 50% of them are satisfied with performance. It's not 100%. There's ejaculations impaired in a large portion of patients with bladder exstrophy, just because of the fact that the bladder, there's no propulsion of the sperms forward. You can get retrograde ejaculation backwards. There's quite a bit of anxiety in 90% of the teens regarding their sexual function and look, and then it goes down to around 24% in the adult population with bladder exstrophy. We did a study together with ABEC using social media for patient-reported outcomes and adult patients with bladder exstrophy. Within were members of ABEC to actually participate in an anonymous survey. What we found is that their penile perception score, that it's a grading system to look at the penile, how they perceive their penile size, their satisfaction of penile length, their orgasmic function, sexual desire, and overall satisfaction was lower than the published control. And so when we asked that group what would they like to see us as a medical community research on, their answers are 3 areas: renal regions, genital appearance, and sexual function. Now we are starting to team up with plastic surgeons who are experts in transgender surgery to try and help us reconstruct panels in those cases that require reconstruction, and different types of reconstructions are available. A lot of the issues with steps could be related to just the skin and scarring in the skin, doing some penile lengthening with skin graft. Some would use, some would require a tissue expander, basically putting an expander on the skin to expand the tissues to allow for reconstruction. And a small percent of patients would require the reconstruction of the penis, especially gynecological patients who require that. And they had a series of 8 patients, and in Hopkins that actually had the neoplasty. Again, it's with a plastic surgeon colleagues who do these types of surgeries. So this is a new era of reconstruction that we're going into. There's quite a bit of research currently, and improvements in sexual or penile reconstruction. And together with the plastic surgeon colleagues, we can hopefully allow for a much better outcome as far as the penis is concerned long term. Next slide, please. So I'm really with male expectation, it should be offered early fertility evaluation, consider the use of assisted reproductive techniques, and really offer them psychological support to allow them to deal with the issue of their phallus or the penis being smaller and not normal, and also provide them with some form of genital reconstruction if that is needed. Next slide. Pam talked about Dr. Hadley, I think transitioning care to adults. Patients are living into adulthood, and transitioning into adults is really, really important. We can take care of patients up until the age of 21, and after 21, let go. I think we're starting to have a transition clinic as the outcomes where we basically provide care together with an adult urologist to have kids be comfortable with an adult provider, and then transition them into adulthood. Really encouraging support and psychological support. Next slide. So as you all know, bladder exstrophy requires ongoing management for life. I think psychological support is paramount to cope with this issue. Transition of care is something we have to provide, and I think collaborative work with others will allow us to improve the care of patients with bladder exstrophy. Thank you. I'll open up for questions. If anyone has questions, personal experiences. I know that.
So what age do you recommend getting early fertility intervention for kids, and also that psychosocial kind of support?
I think starting early with them, I think talking to them early on. As far as fertility is concerned, I think when you look at it's when they're adults, when they're 18 and above. That's really starting the conversation with them.
So like 14, 15?
Even earlier than that.
14?
Yeah. I mean, puberty starts around, even going down to 11 years of age, I think it's really important.
And is there specialists in this area that talk about fertility?
There's not a fertility clinic specifically for bladder exstrophy, but we do have a male health clinic that provides fertility support for all patients. So that's where we would send patients to provide that type of care. Yeah. There's a pretty robust male health clinic as well. Yes. sometimes I think one of the things that we really make sure initially at the initial repair is there's the issue of the kids being dosally in time. And so really making sure that the initial repair is banging upwards. And we've been, and that's been successful in current repairs. The way we repair the corpora is such that we actually, after the initial repair, it should be pointing downwards. The previous repairs that were done in such a way that penises ended up angling upwards and requiring reconstruction. Some of these are related to skin scarring that causes that. I mean, some will have pain, but most of them do not have pain. It's basically, it's the erections that are not normal, that are upwards rather than being normally downwards or straight. Yes.
Reconstruction, at what age do you do that?
Which one? When person is ready for it. I think it's a decision that's made together with the family. Some patients want it done earlier on in the year, but whenever, I mean, we mostly talk to the family, and if they have some that don't mind that, but they can also want it done earlier. So really, the family wants. Okay, one last question on NCG stuff.
Mine is just for the destruction, wait till after they go completely entirely.
Prefer, yes. Unless they have problems with their erection. So if their penis is also what we call also curvature, they can't pee straight. It is very, but if it's just for sexual function, wait.